Bismillahir Rahmanir Rahim. I think we were discussing after lunch that there will be very few audience, and most of the audience are professors. So speaking before them is very difficult. But I'm just उनको याद दहानी कराने के लिए present कर रहा हूँ. अच्छा, the latest guidelines, the world guideline is very significant. Guidelines means that this is a document which is to be followed, and it is very simple for and beneficial for the patient. As you know, there were so many presentations before the lunch. The incidence of diabetes, obesity, hypertension, dyslipidemia, this is increasing over the years. And it is expected that 17.3 million deaths occur due to cardiovascular diseases, and it will increase to 23.6 million deaths per year in 2030. The incidence of cardiovascular disease in Pakistan is higher than the rest of countries in South Asia. If you look at this now, I mean, the incidence is a pointer. Okay. This is the incidence of coronary disease in Pakistan as compared to other countries in South Asia. So the incidence of coronary disease in Pakistan is higher than other countries of South Asia. And the incidence is increasing over the years. If you look at this slide, this indicates the dyslipidemia and incidence of cardiovascular diseases. So in the younger age group, it is very significant, a significant increase if dyslipidemia is there. Initially, there are the risk factors, which is dyslipidemia, diabetes mellitus, and hypertension, which leads to carotid artery disease, coronary artery disease, and aortic disease, and there are vascular complications. Then there are vascular complications and death at the end. This is a score chart of the European Society of Cardiology, which is based on age, gender, diabetes, hypertension, smoking status of the patient. They are divided into low risk, intermediate risk, high risk, and very high risk. Now, the level to treat dyslipidemia was somewhat less than 100 in 2016, but less than 55 in the 2019 guidelines in very high risk cases, and less than 70 in high risk cases. Now, this is a very good slide for primary prevention of the American College of Cardiology. In primary prevention, if the LDL level of someone is more than 190 milligram per deciliter, then it has to be treated with high dose statin therapy. If the patient is diabetic, then the patient has to be treated. But if the level is less than 190, then it depends upon the age of the patient. From the age 0 to 20, if a patient has familial hypercholesterolemia, then the patient needs to be treated. If the age is 20 to 40, and if the patient is having risk factors of dyslipidemia of more than 160, and family history of coronary disease in the younger age group, then these have to be treated. But if the age is more than 40 and less than 75, then we have to risk stratify the patient based on the risk estimator of the American College of Cardiology, which is based on ethnicity, age, diabetes, hypertension, and cholesterol level. So if the score If the 10 years risk of atherosclerosis based on this estimator is less than 10, less than 5, then lifestyle modification should be observed. If the score is more than 20, 20% risk of 10 years risk of coronary disease, then the patient needs to be treated with high dose statins. If the score is between 5 and 7.5, then we have to look for other risks and risk stratify the patient accordingly. And if the score is more than 7.5 but less than 20, then we have to check for other risk enhancer and decide whether the patient needs treatment for hyperlipidemia or not. And calcium scoring is very important in such cases. If the calcium coronary score is less than 0, then the patient does not need to be treated with statins. And if the score is more than 100, then the patient should be treated if the age is above 55 years. Regarding secondary prevention, if a patient is having atherosclerotic cardiovascular disease, then whether the patient is very high risk for further events or the patient is low risk for further events. High risk we have to define based on major ASCVD events. If a patient is having two or more major ASCVD events, then the patient is high risk. If a patient is having one major ASCVD events and he is having risk factors for risk accelerator, multiple risks, then the patient needs to be treated with high dose statins. So for the secondary prevention, the patient needs to be treated with statins, and the goal is to reduce LDL cholesterol level to less than 50% or less than 70 milligram per deciliter. High dose statins should be used, and if the goal is not achieved, then we have to use ezetimibe along with statins. What is high dose statins and what is intermediate dose, moderate dose statins? That is a slide from American Diabetes Association. In high dose statins are atorvastatin 40 to 80 milligram and rosuvastatin 20 to 40 milligram. And moderate dose statins, atorvastatin 10 to 20 milligram and rosuvastatin 5 to 10 milligram are other statins. Now, depending upon how much reduction in LDL cholesterol we need based on the categories of the patient, there are statins should be used in all patients, and if the patient goal cannot be achieved with statins because we need further reduction in cholesterol level, then we have to add ezetimibe. And further drugs like PCSK9 inhibitors, there is 47% cardiovascular risk reduction, 48% stroke reduction, 44% cardiovascular event reduction, 54% reduction of heart attacks, 20% mortality reduction, and 47% reduction in unstable angina due to rosuvastatin, which was proved in Jupiter trial. Statins are a very good drug. They have reduced cardiovascular mortality, but at the same time, there are some risks as well, which and muscles, incidence of diabetes, muscle myopathies, and elevation of liver functions. But the incidence of these is very low. There are some other factors which also makes the patient prone to myopathies. And in our population, the incidence of myopathy is very high, and probably we do not need high dose of statins because most of our patients are doing well. Their cholesterol is very well controlled with 10 milligram of rosuvastatin. But in the West, they are using high doses of rosuvastatin, 20 and 40 milligram. This is a very good slide, which indicates that the incidence of myopathy and LFTs, rise of LFTs is very, very low with rosuvastatin. It is less than 0.5%, less than 5 cases in 1,000. And in our clinical practice, we also see very few cases. So to summarize, cardiovascular disease is the leading cause of death globally. And the risk factors for cardiovascular diseases are so high and they are increasing. It was considered, cardiovascular disease were considered to be disease of the rich, but now the low socioeconomic countries are affected by cardiovascular diseases more than the well-off countries. And the treatment of cardiovascular diseases is costly. We have to use the medicines for long, and these become very difficult both from side effect profile and from beneficiary points. So we have to work on preventive sides and lifestyle more than on medicine. Thank you.